Hello, my name is Hana Afavai, and this is my report on carotid body tumors. So to begin my report, I wanted to go over a case study that I found interesting. It starts with a 42-year-old female who presented with upper lateral neck swelling that persisted over a 1-year period. Her clinical symptoms revealed an asymptomatic slow-growing mass in the neck, while her physical exam included a pulsating, firm, painless mass that measured to be about 4 by 3 centimeters. It was found on the left side of the patient's neck near the angle of the mandible in the left jugular carotid region. The mass was able to move laterally, but not vertically, and a faint bruit was also reported to be heard on auscultation. At this time, the only known risk factors for carotid body tumors are genetic predisposition and chronic hypoxic stimulation, but we'll discuss that more in a couple of minutes. I also wanted to add that this mass was sporadic and it had no genetic ties. Okay, so when it comes to the diagnostic modalities that are needed to evaluate carotid body tumors, vascular ultrasound, CT scans, MRIs, and angiography are commonly used. So if we refer back to the case study, the patient's vascular ultrasound images revealed a hypoechoic mass, which makes sense because those solid masses of tissue are usually hypoechoic because they don't send back a lot of sound waves, and that causes them to be that darker gray color. It also showed increased vascularity at the bifurcation of the common carotid artery, and it also caused that splaying of the external and internal carotid arteries as well. There was no reports of luminal compromise, which basically means that the blood vessel was not being constricted. So if you refer to that smaller waveform image in the top right corner, you can see that it shows the internal arterial flow of this lesion. And so this demonstrates characteristics of a low resistance artery. And thanks to Professor Hart, we understand that low resistance flow is shown through that constant forward flow with the elevated diastolic component, and you also have that consistent appearing waveform as we see here. So as we move on to the patient's CT image findings, we can see that image A is composed of a non-contrast CT revealing the mass with a soft tissue density. Images B, C, and D reveal a bright and rapid enhancement of the mass, while also demonstrating that splaying at the bifurcation of the internal and external carotid arteries. And then image E is a CT angiography image of the left carotid body tumor. I'm also going to briefly discuss the patient's MRI findings, and it really just shows that lesion in the left carotid space. The T2 weighted images also reveal those well-defined flow voids, and flow voids are basically a signal loss that occurs in a patent vessel with blood moving at an appropriate velocity relative to the MRI apparatus. So this doesn't mean that there is an absence of flow, but rather it's a signal loss in normal flow. So regarding the patient's treatment, she ended up undergoing general anesthesia to remove the carotid body tumor. It was classified as a Chamblin type 2 tumor, which will be discussed in some of the following slides. The surgery was successful, and the patient is now asymptomatic with a small vertical scar. I wanted to briefly discuss the anatomy and the role of the carotid body. So this image provided by the Cleveland Clinic reveals the 3 main branches coming off the aortic arch. So the focal point of this presentation is going to be that left common carotid artery and that bifurcation separating the internal and external carotid arteries as they extend up into the cranial cavity. When it comes to the role of the carotid arteries, they're what supply blood and oxygen to your brain. So if we want to get into a little bit more detail, they function as a chemoreceptor that's stimulated by acidosis, hypoxia, hypercapnia, and they also can increase sympathetic blood flow to aid with the autonomous control of blood pressure, heart rate, respiration, and blood temperature. So because this is for my vascular class, I did want to focus a little bit more on the anatomy through a vascular viewpoint. So if you look at the first image, it shows the normal anatomy of the carotid body with that bifurcation separating the external and internal carotid artery. And then if you look at the second image, you can see that hypoechoic mass with that typical spleen that you see of the internal and external carotid arteries. And then if you look at the third image, you can also see that same hypoechoic mass, and it's just shown with power Doppler instead of color Doppler. And so just to dive into that a little bit, color Doppler, as most of us are familiar with, reveals that velocity of blood flow through a vessel. But power Doppler actually doesn't provide any information regarding the velocity of blood flow, and it's actually more sensitive than color Doppler. And it shows the strength of the Doppler signal in color. As you can see, there's kind of the different shades of that yellowy orange color, and that just shows the different strength signals inside that vessel. So looking at the incidence and epidemiology of carotid body tumors, they represent about 60 to 70% of the periganglioma of the head and neck. They are super rare vascular tumors that arise at the bifurcation of the external and internal carotid arteries. Roughly 90% of them are benign, but there is a malignant incident rate of less than 10%. Carotid body tumors are also more common in women than men, and they have a mean age at presentation falling between 40 to 50 years. So looking at the symptoms and presentation of carotid body tumors, they are most commonly asymptomatic. The symptoms don't usually result until there is pressure and local invasion of that surrounding tissue. So really, the larger the tumor, the more common it is for symptoms to arise. So if you are seeing tumors, you will see that slow-growing rounded mass in the neck, and there can also be signs of dysphonia, dizziness, headaches, hearing loss, even cranial nerve deficits if the carotid body tumor is big enough. You can also see physical exams showing that lateral mobility of the mass, and vertical movement is not commonly seen just because of its location within the carotid sheath. So moving on to the pathophysiology of carotid body tumors, we can basically break it down into 3 classifications, which are sporadic, familial, and hyperplastic. Sporadic tumors are the most common type of carotid body tumors. We don't really have a full understanding of why they happen, they just do. The familial classification involves about 10 to 15% of the carotid body tumors. They're more commonly seen in the younger patients, and they involve a genetically heterogeneous entity, which basically means there's numerous genetic defects that it's causing the same disease. The final classification of carotid body tumors involve hyperplastic tumors. So these are the least common type of carotid body tumors. They're commonly seen in patients with hypoxia, and especially in those living at altitudes of 5,000 feet above sea level. I found it interesting that the normal carotid body measures about 2 to 6 millimeters in diameter, but it's often larger in those living at higher altitudes. So that lower level of oxygen at higher altitudes may cause that carotid body to become hyperplastic. There are even some studies that have found that the incident rate of a carotid body tumor is about 10 times higher in people living at 6,000 feet above sea level compared to those living at sea level. I also wanted to mention that it's important to remember that all carotid body tumors have malignant potential, and it's not always possible to predict malignant behavior based solely on histologic features. So there have been some studies that have undertaken the task of identifying histologic criteria for malignancy, some of which are helpful, but future studies still need to be performed. But like I said, at this point in time, there's no definitive, well-accepted histologic criteria for malignancy in really any extraadrenal periganglioma, and that includes the carotid body tumor. Okay, moving on to the labs and diagnostic modalities. We did kind of cover the diagnostic modalities in detail, so I'm not going to spend too much time in those, but considering the labs, it's common to test for urinary catecholamines, beta-amyloidic acid, and metanephrine to see if the tumor is related to a pheochromocytoma. If so, that should be removed before the carotid body tumor is removed. And like we said before, so Doppler, vascular ultrasound, CT scan, magnetic resonance imaging or MRIs, and MRAs are the main imaging techniques used to diagnose and evaluate the carotid body tumors. Okay, so considering the staging of carotid body tumors, the Shamblin Research Group introduced a classification system comparing these tumors and their relationship with the carotid body back in 1971, and we still use this classification system today. So the Shamblin research group described 3 stages of carotid body tumors. Type 1 consists of a small tumor that's easily dissected from the adjacent vessels. Type 2 tumors are larger and are more adherent and partially surround the vessel, while type 3 tumors are large and completely surround the carotid bifurcation. So types 2 and 3 are also more likely to require that carotid resection. Okay, so surgery and surgical resection is usually curative and is a treatment of choice even for malignant tumors, just because chemotherapy and radiation haven't been proven to be of significant benefit. There are surgical challenges just because the tumor is high in vascularity, it's close to the carotid bifurcation, and sometimes even infiltrates the bifurcation. There's also surgical complications, as in cranial nerve injury, but overall it is usually the preferred choice considering the treatment of these tumors. Radiotherapy is usually reserved for those who are poor surgical candidates, like older adults, or individuals who have multiple carotid body tumors that would cause the resection to be highly morbid, but its main goal is to slow or stop the progression, not to reduce and remove the tumor, if that makes sense. I did also want to mention that tumors measuring 4 centimeters or larger typically encounter a higher risk during removal. The larger a carotid body tumor grows, the more adherent it becomes to the vessels and the harder it is to resect. So early detection of these smaller tumors can really help reduce the morbidity of the procedure. Carotid body tumors are often misdiagnosed, and that's mainly because they're just so rare, and it's more likely that one of the other causes below would occur before a carotid body tumor would. And that concludes my presentation. Thank you.